Hello, my name is Nawari McGowan, and today I will be discussing how incorporating routine oral care with 2% chlorhexidine swabs for ventilated patients in the ICU will prevent the occurrence of ventilator-associated pneumonia, which we will call VAP. This simple intervention cuts a significant amount out of the cost related to treat VAP while providing optimal outcomes for our patients. First, I will discuss the educational theory and conceptual framework that's going to detail what my project's about. Regardless of many suggested strategies, the frequency of hospital-acquired infections remains elevated, with VAP being the most common infection amongst intubated patients. The key mechanism for the development of VAP is aspiration of colonized oropharyngeal secretions into the lower respiratory tract. Patients on mechanical ventilation require drugs such as antipsychotics and anticholinergics, while their mouths are kept slightly open from the intubation tube. This causes a break in the balance of the oral cavity, leading to a decrease in the production of saliva, thus creating an easy pathway for bacteria to inhabit. Now, with that being said, there's little doubt that VAP is a major problem within critical care units and a huge economic burden for many hospitals. It's projected to occur in 9 to 27% of all mechanically ventilated patients and is highest during the first 5 days of mechanical ventilation, with the mean duration between intubation and development of VAP being approximately only 3.3 days. When looking into VAP's economic burden, in one observational study, the cost differences between patients in each group who survived until hospital discharge demonstrated a persistent increase for patients afflicted with VAP. The results of this study showcase how patients with VAP incurred greater hospital costs of approximately up to $3,652 more and a significantly longer hospital stay of 10 extra days when compared to patients without VAP. Healthcare costs for patients with VAP were primarily devoted to additional respiratory support and anything involved with longer ICU and in-hospital stays, including medication, which, interesting fact, 50% of all antibiotics administered in ICUs are for VAP treatment. Despite recent advances in treatment and diagnosis of VAP, it continues to be a medical problem of major importance, with an attributable mortality rate between 33 and 50% with no preventative measures. VAP poses grave implications for mechanically intubated adult patients in ICU worldwide and leads to increased adverse outcomes and healthcare costs, thus making it imperative for preventative interventions to limit its occurrence. Now that you are all familiar with how VAP is a problem within our health system, I would like to show how my proposed intervention fits well with the behaviorist learning theory. Ivan Pavlov was the main influencer behind the concept of the behaviorist learning theory, which was founded in the early 20th century. In this theory, learning is the result of connections between the stimulus conditions in the environment and the individual's responses that follow. Behaviorists can closely identify a person's responses to the environment and then manipulate stimuli in the environment to bring about the intended learning and behavioral change. When applying this concept to my intervention, it would flow very similarly in this manner. The stimulus condition would be to change oral care practices from normal saline to the use of 2% chlorhexidine. The desired individual response should reflect a decrease in VAP or complete prevention, thus creating the intended learning behavior by developing motor memory and associating this with positive patient outcomes. Next, I will be going over the educational intervention, just going a little bit about chlorhexidine and the benefits of why we should use it. Chlorhexidine is a broad-spectrum antiseptic agent that is active against aerobic and anaerobic bacteria, and amongst its most important characteristic is its persistence. It remains chemically active onto tissues for up to 6 hours. Observational studies and several randomized control trials demonstrated that antiseptics, oral decontamination agent, including 2% chlorhexidine, can reduce VAP for individuals requiring mechanical ventilation. Of the 207 patients enrolled to the study, the incidence of VAP was 11.4% in the normal saline group and 4.9% in the chlorhexidine group. Numerous studies have demonstrated how oral care with normal saline alone cannot be substantial enough for the body to defend against VAP. Teeth should be considered a significant reservoir for respiratory pathogens, and decontamination of the oral pharynx with antiseptic solutions could decrease the incidence of acquired respiratory infections. Next, I will be going over the stakeholders and what their role is when implementing the process for my proposed project. First set of stakeholders are going to be my ventilated patients. These are going to be mechanically ventilated patients without pre-existing pneumonia in the ICU. These patients will have to be intubated longer than 48 hours for the study to work and will be followed during a 2-week period. I would like to test a total of 20 patients, with 10 patients receiving oral care with normal saline and 10 patients receiving oral care with 2% chlorhexidine swabs. The next group of stakeholders are going to be my patient care providers. This will incorporate pulmonology MDs, ICU RNs, and respiratory therapists. The aim is to make all patient providers mentioned above aware of the new practice change, with the approval of the MD, of course. I will dedicate a set number of nurses to provide oral care using only normal saline for one group and only 2% chlorhexidine for the other group. The number of nurses will be determined based on availability of ventilated patients at the time. Each nurse is to provide oral care brushing the teeth and tongue with the supplied toothlets provided from the hospital and chlorhexidine packs at every 4-hour interval. Respiratory therapists will not be required to provide this intervention. They will just be aware of the project so that outside intervention can be minimized. The next set of stakeholders are going to be my organization administration. This is going to involve the hospital's financial administration, the CEO, and the ICU manager. The CEO's primary role will consist of providing the monetary supplies needed to implement my project for the duration of a 2-week period. The supplies required are 24-hour oral care kits with 2% chlorhexidine swabs and toothlets without antiseptic agents for approximately 20 mechanically ventilated patients in the ICU. The ICU manager will be involved in the implementation process. Their role is to ensure the project is being executed correctly and that the ICU staff recognizes the importance of the new practice change. The ICU manager can direct and facilitate staff assignments to nurses that are participating in the project, while also ensuring the products needed are adequately available when necessary. The last person for the stakeholders will be yours truly. My role will be to ensure my project is being properly conducted. I will provide relevant information to the hospital's administration and ICU manager that detail how well or unwell my project is going. I plan to collect data pertaining to VAP and distributing them after 1 week of trial up to the duration of my project. I will also facilitate educational meetings for all ICU nurses on the importance of oral care, how 2% chlorhexidine is effective in VAP prevention, and what they can do when incorporating this care into their practice. At this time, I feel 3 meetings with ICU nurses is sufficient enough to make them aware of this change. Next, I will go over the actual implementation process of my project. My plans involving the implementation project or process for this evidence-based practice change will start with educational meetings first. I would like to hold a simple meeting with the hospital administration to go over the practice change and how it would benefit not only our patients, but the hospital itself by cutting down a tremendous amount of costs related to treat VAP. Once I have received approval from the financial aspect, I would ensure that our hospital purchases enough 2% chlorhexidine oral care kits made for patients that will participate in the study. The hospital already supplies toothlets without antiseptic agents, so that part's already taken care of. After the supplies are readily available, the next step would be to hold meetings with the ICU staff to make sure they are aware of the new proposal and dedicate certain RNs for the project execution. At this time, I feel 5 ICU dedicated nurses from each shift will be sufficient enough to execute this project. No extra physical training other than a quick observational study to ensure proper technique will be necessary, since ICU RNs are already pre-equipped with knowledge on how to provide adequate oral care for mechanically ventilated patients. After this process has taken place, my next step would be to notify pulmonology MDs and respiratory therapists in making sure the RTs do not interfere with the project. I have already discussed this project with many pulmonologists, and at this time I feel very confident that they will be supportive of my evidence-based practice change, therefore allowing us to proceed with the trial for their patients. After completion of this step, I would then have to limit which patients can participate in the study by process of elimination. I am allowing approximately 20 adult patients, male or female, who are mechanically ventilated for more than 48 hours with no previous diagnosis of pneumonia to participate at this trial for this time being. I would need consent from the patient or family members on execution of this project. Once 20 patients have been identified to properly conduct my proposed change, they will be divided by half and monitored over the next 2-week period for signs of VAP development. I will document the findings and report the results at every week interval up to 2 weeks so the administration and hospital staff know how well or unwell my project is going. I plan to measure patient outcomes defined by the CDC via monitoring chest x-rays, plus 2 of the following symptoms: temperature greater than 100.4, blood leukocyte count of greater than 10,000 cells per milliliter, increasing oxygen requirements, and purulent tracheal secretions. After a 2-week assessment of the issue, I hope to make everyone aware of how VAP can be easily prevented or minimized with the use of 2% chlorhexidine oral care. I realize this intervention will require some monetary involvement to get started. However, I feel the benefits will greatly outweigh the initial costs and facilitate the practice of implementing evidence-based medicine for optimal patient outcomes. As stakeholders, you can ease this transition more smoothly by educating yourselves on the importance of adequate oral care. It is easier for people to actively involve themselves when they feel vested into something they feel will make a difference and make positive changes. Words of encouragement to the participating staff will also help facilitate my practice proposal, since this will require a team effort. My best advice and greatest help from stakeholders would be their tenacity at follow through and ensuring this project is executed properly by having supplies readily available and providing adequate staffing with attention to acuity so the participating registered nurses have enough time to execute oral care. Well, that pretty much sums up my project proposal. I thank you for your time and consideration, and I hope that you will review how beneficial this practice change could be if given the opportunity to implement it. Thank you.